Hi, everyone, and welcome to today's CAP webinar on suicidality and self-harm. Today, we are fortunate to hear from our speakers, Shelly Nakaishi and Wang. Introduce Shelly. She is an assistant professor of family health nursing at the UCSF School of Nursing and is a consultant for the CAP portal. She's a certified pediatric NP working as a pediatric primary care mental health specialist at UCSF with over 15 years of clinical experience providing comprehensive outpatient psych evaluations and treatment for our children and youth in the East Bay. And Dr. Wang is a child and adolescent psychiatrist in the Division of Mental Health at UCSF, Children's Hospital Oakland, and the UCSF Department of Psychiatry and Behavioral Sciences. Clinically, she provides care in the outpatient clinic at UCSF Benioff Children's Hospital Oakland, as well as the UCSF Medical Center at Parnassus Heights. And she is a consultant for the CAP portal and helps to lead planning for CAP's continuing medical education CME events such as this one. And just as a reminder, we will be reserving the last 10 minutes for a question and answer. So if you have any questions for our speakers, please type it into the Q&A section. And with that, I will turn the platform over to Dr. Wang and Shelly.
Thank you. Thank you for the really kind introduction, Dr. Reeder. And I'm Eileen, and Shelly, my colleague, and I will today introduce a few things. And next slide, please. First, this is a disclosure. And this is just wanted to let you know that we're not involved in any financial activity that will be a conflict of interest, and the UCSF CAP program is being supported by a couple different fundings. Next slide, please. So here are our learning objectives for today. Today, Shelly and I will first introduce the terminologies, followed by an introduction to suicide screening, suicide assessment, and how to manage suicidality in pediatric primary care outpatient setting. We will go over different examples for low, moderate, and high suicide risk scenarios, and we will also try to leave about 10 minutes at the end for the Q&A. Given the time that we have today, we will focus mostly on pragmatic practices of self-harm and suicide screening, assessment, and management. Our talk today is not going to cover all the statistics and background information of self-harm and suicide, given the time constraint. However, we will provide examples and hope this will help you think about and integrate these practices in your clinic. Next slide, please. So in the beginning of this year, the Surgeon General warned that there is a youth mental health crisis in the US, especially the surging number of suicide. As you all know, PCP acts a crucial role in suicide prevention. Among people who died of suicide, 80% had visited primary care providers in the previous year, and that most of them don't have mental health care established. Suicide is the 5th leading cause of death among younger children from 5 to 12 years old in the US, and jumped up to the 2nd leading cause of death among older teens and young adults from 10 to 24 years old. If we look at the right lower bottom graph, it shows that suicide is a continuum of thoughts, plans, and actions. So it's not a cross-sectional 1 second of phenomenon that happens quickly without a space or time for us to intervene. Among 10 million people who have serious suicidal ideation, only a third have made a plan, and less than half of them had attempted suicide. Down the line, less than 0.5% among those who had serious suicidal thoughts actually died by suicide. So this really shows us that there are things and there are actions that we can take to battle suicide before it gets to the final step of someone killing themselves. Next slide, please. I also want to bring up the story of Henry Ford Health System and how they started the Zero Suicide Action. So they came up with this idea that suicide is preventable and treatable. in the late 90s. They took multiple efforts, including training their staff, identifying the risk, engaging and treating patients with suicidality, transforming their system, and optimizing treatment for psychiatric disorders. Over the course of 11 years of this project, annual suicide rate dropped by 70%, with at least 1 year out of these 11 years of implementation of the project that there was actually zero suicide. So in contrast to increasing suicide rate among non-mental health patients and general population in the same state of Michigan. So this eventually evolved to the Zero Suicide Project, a national effort over 200 health systems are involved in. And that also started this brand new idea for healthcare providers that there's so much that we can do in this battle. Next slide, please. And all of us can feel confused and overwhelmed when managing suicidality of our patients, especially with limited resources. Learning that self-harm and suicide are identifiable, preventable, and treatable helps us grow confidence in screening for suicide and also making suicide assessment when it's appropriate, and also building that familiarity and confidence with creating safety plans, which do all make a difference for our patient safety. We also found practicing these different practices help primary care providers to successfully detect and manage their patients' self-harm and suicide symptoms. All of us can have our own beliefs, bias, and blind spots, and it's important and good practice to kind of look at them before starting caring for this patient population. Is suicide really preventable? I often ask myself about this question. Can caregivers really help anyone who's cutting? Is cutting really treatable? There's such limited access to mental health resources for suicide treatment. So even if we screen for it and make the assessment, are they really gonna get to someone who is able to help them? We found these questions really valid. And I wanna share one kind of clinical scenario one of my patients had shared with me after I assessed for their suicidality, with some concerns and also some reservation because the patient seems just to be going through crisis very frequently. And the patient actually shared with me that they appreciate me asking that question because they've been hiding this thought as a secret in the bottom of their heart. They don't know who to talk to, and they've been waiting for someone to ask about that question. They've been so scared and feels very alone in it and just not sure what to do. So that was really a changing moment for me because it was so powerful to hear it directly from the patient that asking them about suicide or suicidal thoughts doesn't necessarily increase their suicidal attempts or plans. But by not asking it, it could actually increase the risk. And it can actually worsen their anxiety or depression because they're teenagers, they're kids. They have these thoughts and they don't know what to do with it. They don't know why they're there. Next slide, please. So first, we're going to briefly go over non-suicidal self-injury, which is self-harm, and then we'll go over suicide. Next slide, please. So NSSI, in short, is the most common among adolescents and young adults. Lifetime rates in this population is about 15 to 20%, so it's quite high. And the onset typically occurs around age 13 or 14, so right around the time of hitting puberty. When we see the term self-harm, first we'll think about what is the intent. And that really separates the two, non-suicidal self-injury from suicide. So self-harm is a self-directed and deliberate behaviors that results in injuries or the potential for injury. And when there is an intent to die, then that self-harm is a suicidal behaviors, thoughts, or plan. And when there's no intent to die associated with the self-harm, then it's called non-suicidal self-injury. Non-suicidal self-injury is a self-harming behaviors that does not include suicidal intent it associates with higher risk of suicide. So we often will also screen for it because it itself is a risk factors. And of course, it causes medical problems or concerns that you might need to take additional care for. It may also be complicated by suicidal ideation. A lot of my patients have both self-harming, non-suicidal self-injury, and suicidal thoughts co-occurring. So it's important to look at both. And often is comorbid with psychiatric disorders. So it will be sometimes a kind of a warning sign for us to think about other disorders, most commonly anxiety, eating disorders, trauma, especially physical and sexual trauma, borderline personality disorder, depression, and substance use disorder. Next slide, please. The first step of understanding NSSI is understanding how it serves our patient, because no one likes to just cut themselves left and right. Usually they do it because it makes them feel better or it solves some of their problems. This is from a research that kind of delineated the different functions that a cutting or other types of self-harm may serve a teenager. And they're not mutually exclusive. So if you add all of them up, it will be over 100%. But the most common reason is for emotional regulation and inducing the positive or wanted state. And then followed by escaping the negative feeling, followed by self-punishment, peer influence, ways to show people how distressed they are if they're not good at expressing it verbally. The most common way of self-harm, NSSI, is by cutting or scratching. Next slide, please. It could be hard to talk to teenagers about their NSSI. I find it hard to be the provider that talks to them about this, and the patient's parents often feel really difficult to kind of approach this, the symptom. So here are two examples that I want to share with you. That is based on trauma-informed approach by introducing safety, being transparent with our patients, showing them our concerns and care for them, offering support, and offering collaboration so that we work as a team. And most importantly, empowering the teen by offering them voice and choice, and also understanding where they're coming from. And then the two examples will be, this is like part of the confidentiality that I will do with my patient. I tell them that before we start discussing their psychiatric symptoms or difficult feelings or sensitive topics, and I will say, I will use my best judgment to involve your parents or caregivers if I feel you're at risk of hurting yourself or being hurt. Either it's using substances, self-harming, or killing yourself. And in order to offer them voice and choice, I'll tell them before telling your parents or caregivers. One thing is for sure is we will work together first to find the best way to inform them, so that I wouldn't just, without you knowing about it, go ahead and then tell your parents. I will let you choose whether you want me to tell your parents when you're there, or you want to tell your parents by yourself when we're all in the room together. So at least they have a choice, and I want to hear what is their choice. Next slide, please. The mainstay treatment for NSSI is harm reduction by using direct, non-judgmental questions to understand better of where they're coming from and what's the function and methods of their self-harming behaviors, offering safety planning and make sure that all the stakeholders all have a copy and we're all updated. Means reduction, making sure that the patient doesn't have access to the most lethal means or all lethal means based on the kind of case-by-case scenario. And also offer a lot of parent education, because this could be a very stressful time for parents, and it could also be very confusing for their parents. They often feel really hurt and betrayed that their teenagers are hurting themselves. This is a website that I highly recommend. It's the Cornell Research Program on Self-Injury and Recovery. It offers a lot of background information, example language to use, and also just up-to-date research on NSSI, and also for different types of people, for friends, for parents, for patients themselves, for healthcare providers. And here are some examples that I kind of copy and pasted from their website that I really like, are the example language that you can use when you first have a patient who's engaging in these behaviors, that you will ask them in a direct, open-ended, non-judgmental way, and showing them how much you care about them because you care about their safety and then their physical and psychiatric health. Next slide, please. And this is a tricky situation, but often happens in our clinical work, is when you identify that your patient has NSSI, next step is, who do I tell? And should I tell anyone? Very often the teenagers is going to ask us, please don't tell anyone and keep it as a secret for me forever, if you can. And I usually wouldn't directly answer that question, but I will first ask them what they're worried about and what are the things that they're scared of, because that will be another kind of gateway question to understand more why these behaviors serves them and what is their motivation to stop or to get treatment. But in terms of when to involve and to evaluate the risk of these patients, I think it's important to kind of take different factors into consideration. The timing can be tricky. So there are gray area when it comes to NSSI. This is something that's very different from suicide. For suicide, we always want to find a way to, as soon as possible, involving parents or a caregiver. For NSSI, to inform or not to inform is the question. And we really try to value what is the frequency of their self-harm? What is the level of lethality of their self-harming behaviors? Had there been any previous concerns medically? Has the patient been engaged in treatment? Had the patient has a therapist that they see frequently and how helpful that therapy has been? Any other acute concerns for comorbid psychiatric disorders or suicide on top of NSSI? And taking all these factors into consideration, I would say if this patient hits all of the red flags, then I would try to inform parents right away by saying that confidentiality disclaimer that I shared with you earlier, to offer a patient a choice in what way that they want me to involve their parents or caregiver. And in contrast, if this patient is rather low risk because the method that they use are not very lethal and they're very engaged in treatment, that has a therapist that works effectively with them and they have a good rapport with you, then we can go along with that and consider the right timing to bring this up with the parent if the patient's NSSI still doesn't improve over time. Next slide, please. So that was our kind of quick overview of NSSI, and we're going to move on to talk about suicide. It's going to kind of encompass two main parts, the screening and assessment. Next slide, please. So among youth in the US who died, over 25% died from suicide. So there was a separate national emergency of child and adolescent mental health was declared last year in 2021 by AAP and ACAP. And then the blueprint for youth suicide prevention was released by ACAP in early 2022, which is our collective response to this national emergency situation. And it's a collaborative effort. And then the research is based on a lot of people, a lot of different teams' participation, including interviewing and getting feedback from teenagers. Next slide, please. We're going to go over the most part of the AAP blueprint for youth suicide prevention. And before we get started, I really like how they kind of start with this disclaimer that there are two critical steps for all our PCP and people who work in mental health care before you begin caring and assessing and screening for suicide in your patients. First is to make sure that you're connected with resources, including like pharmacies that have psychiatric medications available, therapy resources in your area, case management in your area if appropriate. And the second step is, going back to the first step, just wanted to say UCSF CAP program, our Child and Adolescent Psychiatry Portal, is actually one of the resources that you're more than welcome to use. And we're there for you for this reason. The second step is understand what we're going to step into. So in terms of suicide, we're going to do both screening and assessment. Screening is rapid, universal for all the kiddos and teenagers who's above 12-year-old. And assessment is for anyone who reports positive on a screening. There are some differences. Assessment is a comprehensive evaluation. It's a brief one, but it will provide you more information in terms of what is the level of risk and let you know how to assess the risk by going through the risk factors and protective factors to determine the risk level. And based on the risk level, you'll be able to move on to the next step for your patient. So these are kind of two critical steps to just kind of check in with ourselves before we start working with our patient who have suicidality. Next slide, please. And the other really nice information that AAP Blueprint also reminded us about is the reason why they want to move the suicide screening to a type of universal screening for everyone who's 12 years old and up, is because it's really one of the most important ways that we can do to promote health equity. All of us have biases. We can easily assume someone, because of their background, their cultural, historical beliefs, or their racial and ethnicity background, that they may be a higher or lower risk for suicide. And in order to combat or to reduce that bias, universal screening really helps us to be able to look at everyone in a more equal way so that we know that we're not missing out on something. Next slide, please. And here is a clinical pathway that we made for suicide prevention, largely based on the AAP Blueprint. This is also available on our UCSF CAP website. If you go to provider resources and then click on suicide and safety assessment, and then next will be multiple different choices. The first one is the pathway. When you click on pathway, you'll be able to see this flow chart. And I'm just going to browse through it quickly, and we'll talk in depth about each step in the following slides. So the first box is safety screening criteria. We sort of talked about this earlier, that the AAP new guideline recommend universal screening for everyone who's 12 years and older. And also they recommend screening for anyone who's younger, that you have any specific concerns. Usually that's because when patients report suicidal ideation, plans, attempts, or they show emotional or behavioral disruptions or other types of concerns. The second box is then use the brief screening. They recommend using either ASQ or SBQR, which we'll talk about in a minute. For anyone who screened positive on the screening, AAP recommends the brief assessment as the next step. And there are 3 different types of assessment that are available on their recommendation. We will largely introduce ASQ BSSA just for consistency of our presentation, because we're going to use the ASQ screening, and then we are going to show you the ASQ brief assessment. But you're also welcome to use a different type of brief assessment that's recommended on there. And then after the brief assessment, we'll be able to determine whether the patient is at low, moderate, or high risk. Next slide, please. And then based on the risk level of each patient, then we'll be able to follow the guideline, which tells us what are the appropriate management for different type of patients. And then, for example, for low risk, usually the patient needs to follow up in 1 to 2 weeks, and we can consider doing a safety planning, but most importantly, we need to provide them resources and crisis numbers to call, such as the National Suicide Hotline 988, and then the crisis text line 741-741. And that's true for all levels of risk. So I would do that for my low risk patient, for my moderate risk patient, and also for my high risk patient. And for moderate risk, we'll definitely complete the safety assessment, do the safety planning, but more importantly, we'll try to follow up with them within 3 days and making sure that they have a more urgent referral to a mental health professional. And then for high risk patient, we'll talk more about that in later slides, that's really when we consider calling 911, working with the PD or the mobile crisis team in your area. And also just wanted to share with you, this is a very small proportion of our patient. Most of the patients that we see who report suicidality are mostly at low risk or moderate risk. The high risk population is really the minority, but we still need to learn about how to manage these situations. And that really helps us to have the confidence to care for our patients. Next slide, please. So we went over the universal screening, more specifically for people who don't have history of suicide. We recommend no more than once a month screening and no less than once a year. So that said, basically says you can do the screening basically at the annual well check. And for anyone who's younger than 12, screen them when parents have concerns for suicidality, when patients bring that up themselves. For even younger patients, younger than 8 years old, they should not be regularly screened for suicidal risk. Most reason is because they don't understand what death is, but we can still assess for the risk assessment when parents report suicidal behaviors. And I would recommend in these cases who are really young but reports concerns for suicide or self-harm, see if you're able to get more information from caregivers about the triggers and the behaviors and what are the consequences. Because a lot of times it's a maladaptive response to something that they don't like. For an 8-year-old or 6-year-old, they don't understand what death is. So a lot of time when they say, I want to die or I'm going to kill themselves, it's a way to kind of express how upset they are. So it will be really helpful to identify what are the triggers and what are the consequences so that we can help parents to adjust or change their responses in order to mitigate some of these expressions or feelings. Next slide, please. So going back to screening and assessment, these are the kind of have the full name written out here. For suicide screening, we use the ASQ, Acts for Suicide, and the SBQR, Suicide Behavior Questionnaire Revised. For the brief assessment, we use the ASQ brief assessment or the Columbia Suicide Severity Rating Scale full version, or Suicide Assessment 5-Step Evaluation and Triage, SAFE-T, which is a 1-page, really short and precise kind of step-by-step instructions on what to do when you have someone who report positive on their screening. Next slide, please. And we just wanted to show you a head-to-head comparison between the two different screeners. Just wanted to let you know that they're actually very similar. You can use whichever that you prefer or is easier for you to access. These screenings and assessments are all free, so they're all available online. We also have some of them on our UCSF CAP website, but you can see they're all asking similar questions such as, do you have any thought that you wanted to die? How often did you think about it? When was the last time you think about it? Have you ever tried to kill yourself? These questions are really helping us to gauge how acute and how severe their suicidality is in just a few questions. For ASQ, note that there are 5 questions, but you only need to ask the first 4. If they're all negative, then you don't need to proceed with the 5th question, which is, are you having a thought about killing yourself right now? And of course, you can tell that is that will be an odd question if the patient answered negatively to the first four. So they are both very brief because they're both kind of 4 questions, and ASQ just have this one additional question to gauge the acuity of suicidality if the patient does report positively on previous questions. Next slide, please. And this is a busier slide, but also, again, just wanted to give you a brief, kind of quick idea of what the assessments are like. So we talked about there are really 2 main parts, the screeners and assessments. So we talked about the screener in the last slide, and this slide is to have a head-to-head comparison of the 3 different brief assessment templates that is available to you. For CSSRS full, the Columbia Suicide Rate Self-Rating Scale, here are the questions or the components on that brief assessment template. And in the middle is the ASQ brief safety assessment template. And these are the components that they include. And then finally is the safety. So you can see that they all are, again, sort of similarly focusing on getting more information on suicidality itself and assessing for risk factors and protective factors, including their social history, psychiatric history, other support, in order to help so that it can help us to determine what is the risk level. And in AAP guideline, they really encourage just to do these quickly. They try to make these screeners and assessment very short. So the goal is to, with practice, to be able to complete the screener within 20 seconds and for the suicide assessment to complete within 10 minutes. And it might take a little longer in the beginning, but once you're getting familiar with this, it is possible to have the patient answer all of these questions in a interview style within 10 minutes to 15 minutes. And again, not all of your patients who are screened suicidality will need an assessment. Most of them will need a screener, but a lot of them are probably going to answer negatively on the screener. Only the ones who answer positively on the screener will proceed with the assessment. And not all of patients that have the assessment will necessarily be high risk. Most of them are actually going to be low or moderate risk that you just need to see them again, either within 3 days or within 1 to 2 weeks, just to follow up and see if they're connected with a mental health provider or even that intake or first appointment being scheduled. Next slide, please. So with this, I'm going to thank you for all your patience so far, and I'm going to turn it over to my wonderful colleague, Shelly, to walk us through more details on suicide assessment and management.
All right, thank you, Dr. Wang. And I saw a lot of the chat questions, so hopefully I can answer some of them in this portion. So the PHQ-2 and PHQ-9 are for depression screening. They're actually not validated for suicide. I know in the PHQ-9 adolescent, there are some suicidal questions. And so what we currently see in primary care is that folks will do the PHQ-2 at the well-child visit for teens. Then if that's positive, they'll do the PHQ-9. And then if that is positive for suicidal, they might do the ASQ and then do a suicide assessment. Next slide, please. And so, when we did this presentation 6 months ago or so, I mean, flashing lights went off to all of our, wonderful primary care providers who have very, very busy offices. And they're like, no, not another screen. How are we going to do all these? And really, the focus of the AAP blueprint is to say that also is that everyone that's depressed doesn't mean they might, someone could be suicidal and they're not depressed at all. Someone could be suicidal and they are doing great in school. They look like they're socially doing great. They're active, but they can still feel suicidal. Someone with anxiety can feel suicidal. So really the AAP blueprint is really trying to say, you should separately screen for suicide. So maybe the proposed new workflow could be you still do the PHQ-2 to check in on depression, but you should include a validated suicide screen like the ASQ. And then if that's positive for suicide, follow on with a suicide assessment. In this case, we're going to present the ASQ. Okay, next slide. So here's what the ASQ looks like. I think Dr. Wang did a great job explaining it, that the first 4 questions are about the suicidal ideation and past suicide behaviors. But and if that is positive in any one of those top 4, then you would ask, is there any acute concerns right now, which is, are you having any thoughts of killing yourself right now? In the coursework in the School of Nursing, when I roll this out and teach this, we actually practice this, and saying the words and asking them, and practicing doing a safety plan, which we'll go over soon. So it helps decrease that kind of fear of saying these words and asking these questions, because when I look at doing a suicide, once we know that the suicide is a problem, then you all have the skill sets to actually continue to do your old carts, which is, how significant is this going on? And how long has it been happening? Where does it happen? And what are the triggers? What makes it better? What makes it worse? And it's using that same type of skills you have, is the same way you look at, this is a suicide. This is a problem right now about suicide. Okay, next slide. So this is positive. Then if that's positive, next slide, May. Thanks. That's positive. Keep going. Then you would do the ASQ suicide assessment. And in this toolkit, you have a lot of the information already. As primary care providers, when you're doing a HEDS, you're gathering their social supports and their stressors. You're gathering how they're doing in school, what's going on in their home life. And then this, I like this tool because it does stepwise approach. So I'll back up and start with saying, first of all, the first thing they want to encourage us to do is say, thank you so much for sharing this information. This must be really hard, but thank you for telling us. This is really important. And then the next step is to actually assess how often. This is using the old carts, really. How often is this happening? Where is this happening? What have you done? What plans have you made? What have you done in the past? And they give you a set of questions to ask. In case you're feeling dysregulated, this is a tool to use. And then the second, as it continues on, you're assessing more for what other things are going on for this young person. Is it that they're depressed? Is it they're anxious? Is it, are there any substance use issues? What's their sleep like? Are they not eating? Is there an eating disorder as well? So it's prompting you to continue to keep your hat on and looking at detective wise, what else is going on that might be a cause or stressor that actually caused them to be more suicidal. Was it a breakup? Were they being bullied? And that's part of the other questions to ask. Next slide. So yeah, HEDS is part of this. So then it kind of gives you a guide. We recommend interviewing the patient alone first as a teenager, and then using the wonderful words and verbiage that Dr. Wang presented about how to discuss and bring up that now we need to share this information with your parent and guardian. Is this something that you want to bring up? Is this something that you want me to bring up? We are going to share this with them. And so being trauma informed and giving them a choice in how to deliver this information. But then it's after we've disclose this with the parent and guardian, it's really the section 3 is kind of helping you gather more information from the guardian caregiver, what else might be going on, and an opportunity to ask, is there a gun in the home? I also like to ask the youth, is there a gun in the home by themselves? And then of course with the caregiver there present. And this is where we put our detective hat on again, and we're trying to find out any other risk factors that are happening that the young person may have not disclosed. And then we give a chance, and it says, hey, caregiver, is there something you want to tell me alone that might be going on too? Step 4 in the ASQ suicide assessment is to actually make a safety plan, and they kind of walk you through. So it's one tool that does it all as far as assessment and safety planning. So coping strategies, really focusing on means restriction, which is our biggest suicide prevention, making sure and talking about even guns and really having a very non-judgmental approach in talking about guns, and then finding out how they secure them, where do they secure them, asking them if they have any other lethal means in the home. And then the step 5 is to determine, okay, what is the risk, low, medium, or high, and do we need to get further evaluation and the follow-up plan? And they give you those options and help you walk through that. Okay, next slide. So I really like to emphasize the importance of safety planning. The ASQ provides that verbiage to walk you through doing the safety plan. The other tools that they recommended in the AAP blueprint, they don't do that in the assessment piece, but it is part of your suicide assessment, is to do a suicide plan. And the AAP blueprint says that you should be doing a suicide plan. So these are the main 7 areas of it. Definitely, I do this alone with the patient first, and I ask them, what are their warning signs? How do they cope? Who they identify as someone they can reach out and talk to, within their friend group, within their adult mentoring group, and then who they're involved with as far as if they have a therapist or at school, or medical providers, really talking to them. Okay, if you're going to think about overdosing on using medications, where are the medications located? And I'm asking the teen all by themselves, where are they kept? How do you get access to them? What could we do to move them in a place that would be safe? What ideas do you have to do this? Then I send up a plan of, can you commit to coming in and seeing me in 2 days? And I'm very specific in my languaging and my timing. And then, of course, they're saying, make sure we communicate this and giving them a copy of this safety plan. We don't like to use suicide our safety contract, because that means, like, if you break it, then something bad could happen. And this is a collaborative treatment plan that you're going to come back to and continually to update. It's a working plan. I feel like when I complete a safety plan, that actually is my biggest factor of knowing, oh my God, they have no coping skills, they have no social supports, they don't tell me anything, then the risk is much higher. So it's definitely something to use to help determine risk level. I also like to include the poison control number on my safety plans, just in case anything and an overdose did happen. And then after I've done the safety planning with the individual, then I bring in the caregiver and I go over this with the caregiver and I double check. If the caregiver says, oh, I lock everything up in this location, but then I'm going to ask the youth in the room, hey, do you know how to get access to that locked box? And they go, yes, I know exactly where they hide the key. So then we have to redo the safety planning. So I'm really diving in and being very specific, and asking those questions and asking, the caregiver, can you put these things, can you store them at work for this month while your son is so depressed and suicidal? Okay, next slide. All right, I'm a very visual person, so I created this visual slide to kind of, again, help me come up with a risk. And actually, Dr. Graham, one of our psychiatrists in the past, helped me. She was part of building this. So it's like your protective factors and your safety plan. Those are the things I'm weighing against the risk factors, which are, and the risk factors kind of outlining the ones in the pink purple about suicide is like, how intense is the suicidal ideation? What's their intent? How lethal is it? How much access to means do they have? That also starts to weigh in the risk factors. So balancing those out help me come up with my risk as far as low, moderate, or high. Next slide, please. And so breaking it down with words now, with low at the bottom left, it's like, there are modifier risk factors. They have a lot of protective factors. They have some ideation. There's no plan or intent or behaviors. And they're open to receiving interventions as far as a referral. And we have a follow-up plan. So that's low. versus moderate, you start to, again, weighing out those factors, risk and protective factors, and increasing intensity of their suicidal thinking or plans. And of course, if it's high, then all those are up. Okay, next slide. Hope that helps give a visual way of looking at things. This is directly from the AAP blueprint, and it talks about low suicide risk. And I think Dr. Wang's done a great job emphasizing that there are a lot of people that think about suicide, but most youth do not require emergency care. And that, and it is really up to you. Some people feel like having a safety plan is helpful for the young person to take. I like to have in all of my after visit summaries, no matter what they're coming in to see me, but of course it is for mental health, but it includes the 988 suicide crisis numbers. It includes other crisis information about the nearest unit, like Willow Rock. And then I include the poison control number. But I do want the young person to walk away with these critical numbers and a follow-up plan if there's low suicide risk. Okay, next slide. So for moderate risk, it's we want to try to connect them to their therapist and inform their therapist if they're feeling suicidal. Again, many times a young person will tell their primary care provider, and they actually will not tell their therapist. So it's really important to reach out and do collaboration. If they don't have a therapist, this is the time to call in your office to the access line or to their commercial insurance to get them a therapist right away, because now you can say, we need this. This is a moderate to high risk, and we need a therapist, and it helps to enact that. And then if they can't get in to see their therapist or their psychiatrist, then maybe you are going to check in with them in 3 days and give them a call or have a follow-up visit in a week. And if the families, of course, or the youth are feeling like they can't keep this young person safe, then the next step is to have them to enact your crisis protocol. And we'll talk about that next. Next slide. So for high suicide risk, again, really emphasizing the importance of sharing and praising them for sharing their feelings. And then when someone is high risk, you already have a protocol in place in your clinic that you should have somebody monitoring this patient at all times. If you have to step out, is there somebody who can observe and monitor and make sure the room is safe? And then if you can safety plan them home, or the mobile crisis comes out and says they're safe and they come back, you definitely want to have them come back in 72 hours and check in and make sure they're linked to services. Next slide. I'm running out of time, so sorry for my fast talking, but I think maybe people think it's normal for me now. So every clinic should have a procedure of like a crisis, whether it's like a volatile patient or for suicidal patient or homicidal patient. They are the ways that we keep ourselves feeling calm, because we have a procedure to follow, and we call ours code gray. We're constantly working on it in our outpatient psychiatry and modifying it. It's a way that we identify, how do I know the front desk? I have a suicidal patient. I need you to call security, and security, then I need my backup person, my consult person to come in and support me. Who's going to help me determine if we can safety plan them home, or we need to call mobile crisis or the police to come in to the clinic to continue on the evaluation. And then how do we coordinate how the ambulance is going to come on board or not? Next slide, please. And then this is just an outline that, to explain to patients, families, that you can have a medical crisis and you go to the emergency room. You can have a mental health crisis and you also go to an emergency room to be seen. This is the kind of process and steps that occur. There are some special units like the crisis stabilization unit. There's one at Willow Rock. There's one in San Francisco, Edgewood, that are specifically for psychiatric crisis for young people, instead of going to the hospital. The other part I like to kind of tell primary care providers is, when you call the police or mobile crisis, you're not writing the 5150. They are going to be evaluated. You're having them come in and evaluate, and whether or not they do a transport hold for them to be taken to a place. a psychiatric place to be evaluated if they needed to be placed on a 5150, 5585. Okay, next slide. And it's always a risk benefit of should they be hospitalized or not be hospitalized. And these are just some factors we wanted to kind of outline for folks, that there could be financial challenges, and that we just always to check in. Sometimes our young people like to go to the hospital because they get well fed, it's a break, they don't have to go to school. And it's so you're checking in on any possible reinforcing factors as well. Next slide. These are just some specific suicide treatment therapies. And it can be hard to get into a lot of these programs. A lot of therapists out there actually do parts of this treatment. Next slide, because I know we want time for questions, Dr. Reeder. And next slide. It's really a balancing act of how do you assess and how do you be compassionate, and how do you put the detective hat on and really finding out the risks for this young person. And it's I like the visuals, again, just how you have to balance all of that, and for like a 15-30 minute visit. Next slide. And these are the CAP website resources that Dr. Wang mentioned specifically around suicide prevention and assessment. All right, 7 minutes for questions.
Thank you so much, Shelly and Dr. Wang. And we've had a lot of wonderful questions, really interesting dilemmas in our Q&A. So a lot of them we've addressed in the Q&A already, but I want to, offer the time for us to actually discuss some of these questions. And I think one of the questions that's coming up right now is whether we have suggestions for alternatives to engaging in self-harm. So for example, a therapist has told a PCP that snapping rubber bands or rubbing ice cubes for patients helps reduce self-harm. Do you have any other tips for some ways they can avoid harming themselves, but still get some sensation to calm themselves down or make them feel better?
That's a great question. And in dialectical behavior therapy, they talk about some coping skills, distress tolerance skills, like taking a warm shower, cold shower, splashing your face with cold water, putting a cold washcloth in the back of your head or your forehead, trying to change the sensations in your body, or doing some running or jump roping to kind of change your heart rate. So those are some others. I look to the youth to see what creative ways they have in thinking about coping in a different way. And it's kind of using your motivational interviewing to try these different alternatives. Anybody else? Dr. Reeder, Dr. Wang, or anybody in the attending who has other ideas?
Thanks, Shelly. This is Eileen. So I think that's a great question, and it will be really useful to offer the alternatives. And also, I think what I have seen being useful are also offering the team different coping strategies. So the alternatives usually work better when they engage in NSSI because they want to elicit certain physical sensation. So it may not necessarily work for everyone. And other things that may work are meditation, mindfulness. For most of the kids, a lot of them will tell me that taking a walk, chatting with friends, listening to music, and taking a shower works. So these also create kind of bodily sensation, and that can be offered as an alternative as well. And besides that, meditation, mindfulness that I mentioned earlier.
Thank you. There's a question about any advice for, suicide assessment, screening, and the conversation when it's a telehealth visit.
Yes, just like you have a procedure for in-person crisis, you should have one for when you're on video visits. If you can set up like any behavioral health support that could come and join your Zoom. It's really critical in the beginning of your visit, your video visits, to kind of identify where is this young person located, who's at home with you, and if the parents aren't home, getting the parents or contact information before you start the visit, and of course talking about confidentiality and risks before you start the visit as well. But then you would call the mobile crisis or the police to come to the home if they could not commit to being safe and having a solid safety plan. Dr. Rita, can we talk about the one question about the suicide risk on the problem list? Because I think that's a great question.
Yeah, please.
I think as part of your workflow is putting this suicide on or non-suicidal injurious behaviors on the problem list. I do think it is something to do and have to alert folks. And I also think when they're not having those and they're no longer having them, to take it off or to change it, to put it in the history. I have heard from youth that they were suicidal and felt suicidal like 5 years ago and still on their problem list, and they still get it asked, and they're like, why do they keep asking me? I'm not suicidal anymore. And they asked me like 10 times over, and during the year. So that is just making sure that you have a good clinic procedure to kind of alert and how to address it and when to screen and ask it and how to take and remove it down or put it into history.
Yeah, totally. And also, I just want to add one more thing that came across my mind that I meant to mention earlier and didn't, which is if you have a patient who had reported suicidal risk before, either a positive ASQ or a positive a concerning moderate risk assessment, the next time when you see them, you don't need to go over all of the questions, like exact questions again. I think you can start with just one most important question, which is how do you compare it with the last time, like with last week or from 3 days ago? Has the acuity, frequency, the way that you think about it had changed? And you can just start from there and then revise on top of your previous assessment. You don't need to do the whole thing again.
And we're not having a universal screen on homicide screens unless we feel like there's a lot of like aggressive or depressed behavior or bizarre thoughts. Then we're going to do the screening on safety around homicide.
So we have about 1 minute left. There is a question about joint custody, co-parent refusing behavioral health. Is it okay? What do you think, Shelly and Dr. Wang?
Or Dr. Reader. I
Yeah,
think that's tricky.
Yeah, I tried to answer it online earlier, and this is a really tricky situation, and that will basically depends on the acuity of the patient. If the patient is currently having moderate to high suicidality, and you're almost thinking about referring them urgently to mental health care, then that need for getting both parents' consents could be exempted. But if they're not acute and they have low risk and they're hanging in there, then yeah, that will be very tough. That we'll have to continuously work with both parents to see if we can get both of their consents.
Oh, and Dr. Ru just put in some information about, they had a young person who died right after they were hospitalized, and that we know the highest risk of suicide attempts and death is actually after a hospitalization. And the hospital should be discharging and making sure they have a follow-up appointment within 2 days. And so that's how the system is trying to address it. It's very, that's very tragic.
Yeah, it's really hard to hear that. I hope that your office, Dr. Ru, your office is able to kind of get together to talk about that experience for the provider. And usually what we do is before the patient is discharged, we try to make sure that they have at least one visit set up within the week, hopefully, with a mental health provider. And I often will also see the PCP tries to see them soon. Also like within a week or 2 weeks after they're discharged. So I think setting up those appointments before they're discharged is really the responsibility of the inpatient team, and that would be a safety net.
Okay, it looks like we are past time. So just want to thank everybody for joining us today and for your really thoughtful and interesting questions, and for Shelly and Eileen for their time and expertise. And we look forward to seeing you at our next webinar. Thank you.